Major funding for these programs is made possible by grants from Capital One Bank and Perfect Building Maintenance, Murray Hill Properties, SJP Properties, Cushman & Wakefield, Greenberg Traurig, LLP, New York Community Bank, Bank of America. Additional funding for these programs is made possible by grants from Akron Gold Brothers, LLC, C.B. Richard Ellis, City Investment Fund, ESSEX Capital Partners, XL Realty Advisors, First American Title Insurance Company of New York, GEMINI Real Estate Advisors, GVA Williams, Hal Fettner, Durst Fettner Residential, Helmsley Spear, Herrick Feinstein, LLP, Jackson Development Group, James D. Kuhn Real Estate Institute at Syracuse University, James Orphanides, John Katzimatidis, KILROY Metal Products, New York's Window Company, M&T Bank, Madison Realty Capital, Marcus and Millichap, Massey KNAKAL Realty Services, Meridian Capital Group, Muss Development, Newmark Knight Frank, Palin Enterprises, Rosenthal and Rosenthal, Sheldrake Organization, Signature Bank, Sterling and Sterling, Stephen Napolitano, Stonehenge Partners, Studley, the Moynihan Group.
Hello, my name is Michael Stoller. You know, New York City is the healthcare capital of the world. This is the place where you have the best doctors, the best hospitals, the best medical schools. And, you know, it really takes care of everything. But we're in critical crisis, the economy, the world, everything. And today I've brought together the keys, the gurus, who are responsible for running the major hospitals and medical centers in New York. My guests today are Dr. Herbert Pardes, the President and CEO of New York Presbyterian Hospital Healthcare System. Dr. Robert Grossman, the Dean and CEO of the NYU Langone Medical Center. Coming in from the borough of Brooklyn, a Brooklyn College alumni, Stan Bresnoff, who is the President and CEO of the Continuum Healthcare. And last but not least, the head of the Montefiore Medical Center, an Einstein graduate, right, from the Bronx office, Dr. Steve Safier. We were talking prior to the show, you know, we have a terrible economic condition. We have budget reductions. We have major losses of philanthropy. We have malpractice insurance problems. What's going on? I mean, you're the biggest employer in the city of New York, second to the city. I mean, all of you represent so much of the employees of the world. What's going on?
I think that the economic conditions of the country are threatening the New York healthcare enterprise. And I think several things are at risk. Number one will be the ability to sustain quality care. There's some wonderful institutions here with very slim margins to do everything they can to try to do the best for patients. I think that's in jeopardy. I think the ability to capitalize on healthcare and its positive possibility in terms of biotech, medical research, things that can generate activity for the city and state are also going to be jeopardized. And I think that we are at risk in terms of jobs being lost in the healthcare sector and services and perhaps institutions being closed. So I think we are in a real crisis, and you said what some of the factors are, but just to be clear, we have big state cuts that we're threatened with. There are federal cuts being talked about. Philanthropy is down. The investment portfolios of places are down. Pension and malpractice reserves are create another pressure for us. A lot of pressures on a healthcare system which has always had thin margins, used the philanthropy to make it up, and is now, I think, a worry for the entire area.
But you know, Bob was saying before, in profitability, New York State ranks 49th out of 50 states of healthcare systems. How do you compete? I mean, there's the UPMC, University of Pittsburgh Medical Center, there's the Cleveland Clinic, there's the Mayo Center. They advertise, they were, in the newspapers, some people have a doctor's radio station. You're all advertising. How do you compete and how do you build? Because that's part of what our discussion is. How do you maintain your infrastructure? How do you build new hospitals? How do you build new emergency rooms and so on? Bob?
Well, it's a very difficult proposition, clearly, in the face of low margins and a highly capital-intense needs of both hospitals and schools of medicine. Without philanthropy and without significant state help, it is very, very difficult to compete at the national level. And what you find is there's a tremendous divergence in curves between New York City, New York State institutions and institutions outside the state, which are probably less regulated, are much more positive when it comes to hospitals, medical centers, academic medical centers. And I think there are tremendous challenges. There's no question about it. Superimposed, I think, on what Herb said are just the indigenous issues with respect to New York City, which we talked about. The price of labor is high, the price of land is enormous, everything costs more in New York. It costs more to recruit individuals, et cetera. So it is a major problem for healthcare in the city and in the country.
But, we were saying prior to the show, Steve was talking about your employees. I mean, how many employees do you have in the Bronx?
16,000.
And how many of them live in the Bronx?
60 to 70%.
If we have cuts and we have these problems, these employees, these are the backbone of the city of New York. Where are they going to go? They're going to go back. They have to have jobs. We're going to lose jobs. We're going to lose health care. They're not going to be able to go. They're not going to have health insurance. We don't have universal. What's going to happen?
Well, I think my colleagues here, and we've been talking a little bit before the show, we all agree that New York has been and should always be a leader in healthcare. And what's, I think, most compelling about the New York story traditionally is we remain very high-minded, but at the same time we take care of vulnerable, poor communities with real severe public health needs. So in the borough of the Bronx, when you look at issues like diabetes, which are twice as high as Manhattan, and twice as high as most cities in the country, or you look traditionally at the needs of HIV patients and the homeless and the mentally ill and the vulnerable, you're talking about a potential public health catastrophe. So not only are we in the middle of economic calamity, it's national or international, but in this very important city for the world where we have lost a significant sector for the moment. It's down. It'll come back. Wall Street. We need to look.
Steve,
we need to look
certain
to
people said to me,
unfortunately,
certain parts of Wall Street will never come back. Certain of them are gone forever. I mean, no one would believe. When I do real estate shows and people say, a credit tenant. Everybody thought AIG was a credit tenant. Everybody thought Lehman Brothers was a credit tenant. These aren't credit tenants. AIG is giving up 3.8 million square feet of space in Lower Manhattan. Merrill Lynch has announced that they will probably be closing 5 million square feet of space. If they are laying off 3.8, there's going to be layoffs in all different aspects. And they go to Continuum, they go to NYU, they go to New York Presbyterian, they go to you. You have people from the Bronx as patients, you have people from Westchester. You're serving both communities.
Well, just where I was going was that healthcare is an industry that we could look to for tomorrow. And I think it is a critical industry when we're thinking of how to restart the economy. And New York should be a leader in that.
But I think agreeing on that point is what Herb has had, right near New York Presbyterian up in Washington Heights. You've had the Center for Biotech. for a number of years. What's happening over there near NYU, you're going to have a new Alexandria Health Center is building a center for biotech. Stanley, you've been involved with healthcare going back to the Koch administration. What are you seeing?
Well, a couple of things.
I won't say Jack Newfield's comments.
A couple of things I would emphasize. New York hospitals have been in a capital crunch even before the current crisis. The low margins that have been described earlier in the discussion have been characteristic of New York hospitals for many years, translating into a scarcity of necessary resources, not just for investment in new programs, but in maintaining quality, physical quality institutions. Secondly, we can't emphasize enough, I think, how poor people, lower income people, get access to health care in New York City to the degree that they do. They are tremendously dependent upon the academic hospitals that are represented in this group. All hospitals are facing challenges, but when you look at the academic healthcare institutions, they are the providers. Maybe 70% of all Medicaid outpatient care to the poorest people in our city comes through these academic health centers, who are threatened in a variety of ways by this juggernaut of the declining economy, the pressure on federal and state budgets, the continuing erosion of commercial insurance payments. I believe that in order to get through this next period, we're going to have to work even harder than before on the management of our institutions, and frankly, we're going to have to work very hard to make our case to policymakers and to the keepers of state and federal coffers that this is too perilous an area to take chances on, that to the degree that things like these budget reductions take place and the public health catastrophe that Steve referred to begins to take place, it is very hard to rebuild that. It is very hard to regain the momentum. And in fact, it isn't just a question of our competing with institutions in other parts of the country. It's our ability to fulfill the fundamental mission that we exist to implement.
You know, if I could just pick up on what Stan said, I want to refer back to what Bob said. There are some very difficult things about New York. Bob pointed out the cost of whether it's construction, whether it's staffing, whether it's materials. Everything costs more. It's harder to build. It's harder to do a lot of things in New York. At the same time, New York has some spectacular aspects to it. I mean, probably many of us in this room, I'll speak to myself, this is to me far and away the greatest place in the world. Now, there are good reasons for that, some of which include the fact that it is a wonderful culture of caring for people who need. I think New York is as concerned a culture, responsive to people who should have services as you'll find anywhere. Second, it is a very generous city. It is one of the best places for philanthropy. It's not surprising that our friends from Pittsburgh and Cleveland are often visiting in New York because they come to take the philanthropy back to their respective cities. So those have been helpful. How have we made it work to this point in a tough, expensive city with very thin margins? Often we've done it because the state has helped, because there's been philanthropy. What Steve was saying before, I believe, is that this also, among the various areas of the economy and the society that have promise of expanding and helping us to get back as a society, is a very strong place. Biotech, new research, treatments, inventions, devices, all can be a tremendous spur to the economy and is a tremendous part of the economy. So not only are we concerned about the devastation of the healthcare enterprise, we're also concerned about undercutting one of the few areas which could help us get back economically.
Yeah, I think that when we look to the future during this period, and we all are going to be doing what Stan says, we're going to be in an intense manner looking at all our operations, and this kind of period stimulates that. So we're going to be responsible, but at the same time, we need to think about the people that work for us, the communities that we serve, and how we all collectively get out of this calamity. In my mind, healthcare for New York is the ticket.
But you know, each one of your institutions, you know, Bob, NYU was created in the mid-50s. You have a hospital built in the 50s that needs construction. The original Presbyterian has gone through so many changes, and you have new buildings being built. Continuum, which, you know, if you really look at it this way, Beth Israel was built in the 40s, 50s going on. You know, Montefiore was built over a variety of things. So we have money that has to be spent, not even to build new buildings or to not build new centers. We just have to maintain these facilities. We have to get, you know, you got to get rid of the asbestos. You got to get rid of the lead paint. You got to get rid of that. You know, I mean, my joke a couple weeks ago on the show was, you know, I was no great advocate of GM being bailed out. I mean, do we do a TARP benefit on the New York on the hospital system around the country? I mean, certain, you know, your margins are lower. Maybe what do you think? How do we do this? Because you do need money for this renovations of your buildings. You need this money to build new facilities, to have the state-of-the-art facilities, to do the type of work, the radiological work or the diabetes work or the other things. How do you do this?
There are two fundamental points, both in some jeopardy here. The economic stimulus package aside, I don't know what will be in it, but most New York hospitals that have embarked upon capital programs to revitalize existing facilities have had to rely on the HUD FHA program of loan guarantees. That's become tighter. That needs to be more expansive, probably not just for New York, but without it, it is hard to see how hospitals in New York City can do the necessary reinvestment in their facilities that you've alluded to. But that ties to something else, because what you get out of HUD and FHA is a guarantee. You still have to pay for the money that you borrow. It's the nature of our society, and pay at fairly high rates. That requires margin, and as the Catholic sisters in the Midwest used to say, no margin, no mission. In this case, no margin, no capital investment. And not to speak like a Wall Street financier, I'd never passed the test. The fact of the matter is that all of the pressures we're facing contribute to the reduction of virtually invisible existing margins as it now stands.
I mean, prior to the show, Steve was saying that he had his best year for the hospital operation last year.
Correct.
But when you took in the effect of the loss on your investments portfolio,
it wiped out
your bottom line.
New York Presbyterian had the same exact situation. You know, I want to go back to one of the things that, first of all, I think one of the best things that's happened in a while is an administration that's taken form now, which I think is really encouraging, one of the few bright spots on the horizon. Excellent. And there are a couple of things that they are looking at. One is that whether in the stimulus package or beyond, they get the importance of information technology. Information technology's potential to improve healthcare and find efficiencies is spectacular, and they're talking about putting some real money in. My hope is that they put in money to the providing institutions, because to put those things up are costly, but whether it's elimination of redundant tests, better healthcare, information technology is great. A second thing that's been discussed is a possible Hill-Burton too, and it's right off what you said, Mike. These institutions are large. We're about 9 million square feet. You know, we have to be working to keep those institutions up to snuff. We have regulatory surveys on a regular basis telling us what we should be doing. Hopefully, if there's something which attends to hospitals' capital needs, whether it's for information technology, for buildings, for fire systems, for whatever, that can be a tremendous help.
We were saying before, even though, you know, there are hospitals and there are physicians, most people, a lot of the people who walk in go to the emergency rooms. Your emergency rooms are flooded, and you can't handle this. I mean, And I know you've had expansions of your emergency room. I know that St. Luke's Roosevelt has had millions of them, and I bet Israel's doing a new one. You've had expansions of yours. How do we take care of the emergency rooms? How do we take care of the patients?
What Herb just said speaks to, in my mind, is the key to beginning to get a handle on how we manage care. Health IT would be the greatest leverage that we could have for reducing unnecessary usage, or usage that could be prevented. And I say that again, usage that could be prevented, because things happen now that people look at and say, why was that patient let go so long? Well, they were let go so long because the information on them is not available when they go to different facilities. Any one of us in this room could go to a physician on Park Avenue and be referred to a specialist down the block, and that specialist wouldn't know what happened to your first physician. So I agree with you, Herb. I think one of the most important components of stimulation and investment in our industry would be through health IT. They're talking about billions of dollars. The former administration, and this is the ray of hope, invested $50 million over 8 years.
Right.
$50 million from federal government in health IT.
But let me pick up on what Steve said, just to show an example from the vantage point of a consumer. What I think IT will be, information technology will be able to do, is offer you the opportunity to put your health care information in one reservoir. Then no matter where you go, if they're connected to that system, you, the patient, can decide you're ready to call up that information. So just like Steve said, you went to one doctor in one place and then to a second doctor in a second place, you can say, go into that, get me the information.
Which is which I was saying to you before about this eHealth, this company who came to me with this e-ticket, where they didn't capture the information on the patient. What they did was, for the hospital, for the provider, is they told you what you were covered for. I mean, which was a different idea, which is necessary also, because you want to do the best services, but you don't want to do unnecessary testing.
There's another aspect to this that we haven't talked about. People come to emergency rooms for reasons, and I think they're pretty well known. There are people without coverage. There are people without ready access to the high-quality primary care. We invest in emergency rooms both to better serve our communities and for business reasons, because it's a way to meet the needs of people.
It's also a feeder. It brings it to...
And it's pretty clear, though, that while we're grappling with these issues of availability of capital and the erosion of our investments and so on, that there is a need to think creatively about models of care delivery. And IT is an important part of remodeling some of our systems of care delivery. But ironically, the current reimbursement system and even the prospective reimbursement systems do not incentivize primary care. We need to have resources that are applied to primary care and to IT, so that in fact we can get about the business of reshaping the care delivery system so it better meets these imperatives, and we can't do it at the cost of further eroding our academic health institutions. Okay. This is part of one aggregate system that has to work together, and there's no evidence that anybody's focused on that.
Okay, I have 2 points that I'd like to bring up. You talk about, the emergency rooms partially being a feeder, they're taking care of the consumer. I understand you're in some Duane Reads. You have certain locations in Duane Reade. You opened up a place called Trinity Center. You have off-campus sites. So this is one situation that you're trying to build business through another thing. But prior to the show, I said it's wonderful and it's very important that you have a great diabetes center. You have a great diabetes center. You have a children's hospital. You have a children's hospital. You are building a children's hospital. You have an orthopedic institute. You have an orthopedic. No, you don't. You have an orthopedic department. You have an orthopedic institute. All these institutes, cancer. I mean, how many do we need? Wasn't there a discussion of maybe there's too much duplication?
There are 20 million people who live in this area, so let's be careful about. You know, Steve is in the Bronx. What, you got 3 million people there? You know,
It's 1.6 million.
No, it sounds like 3 million. It's
a
only
million.
500,000.
we have millions of people in each of these boroughs.
I'm just stirring the pot a little.
1.6 million is the 10th largest city in the country on a standalone basis. It deserves a children's hospital, it deserves an orthopedic institute, it deserves a transplant service, and it's not in competition.
Do we have
any
my
colleagues here.
Do we have VA hospitals? Do we still have VA hospitals? Do we have health and hospitals? I mean,
the likelihood is that 6 months and 9 months from now, we're going to be, if we sit here again, we will find we'll be sitting here with less hospitals functioning in New York.
No question of that.
But if you're looking for that as the salvation, as if it's a terrific thing that we're going to squeeze some hospitals out, some hospitals are ready to be squeezed out right now, and almost nothing needs to be done. I'm concerned about the fact you've got some of the major institutions in this city who are barely making it, and with these kinds of collective hits, we are in trouble. We are in danger of not being able to supply care which is of a high quality. People will need it, and we're going to be handicapped from being able to do it.
None of us are opposed to healthcare planning, and that's what you're talking about. But healthcare planning means not leaping to conclusions that something is necessary, and not leaping to conclusions that something is redundant or unnecessary.
I'm not.
No, I'm not.
I'm not negating the need for a children's hospital in the Bronx.
Of course not.
Okay, you know, any of that.
Absolutely, I understand. I'm trying to say
thinking and analysis.
And
right,
that
I'm
was careful planning when you built your children's.
Now, there may be an argument that ordinary community hospitals ought to reduce their pediatric capability in deference to the centers of excellence in children's care. And there may be a case for other centers of excellence. By the same token, planning ought to look at providing the support and the wherewithal for those things that are required in every neighborhood, in every community. So we're all for a reinvigorated healthcare planning that would get at some of these questions without any preordained outcomes or assumptions.
Stan said it earlier. The children with asthma, which was an epidemic in the Bronx, probably 3/4 of those emissions, with careful planning, coordination, and regionalization, those emissions could be prevented. And if they were prevented, our institutions would be stronger, the people would benefit, and the children's hospitals that we have and run would be focused on what they should be focused on.
Okay, but isn't that also part of the problem, that there's not enough initial screening?
No, but Stan said the health system is not rewarded for screening and prevention and primary care. It's a losing enterprise.
Although, you know, I would be careful to say that we're not starting from scratch. At some of these institutions, the very programs which showed that children's asthma could be handled by better health care and better knowledge about a child and family came out from some of these institutions.
Exactly.
So we're not exactly new to the game of trying to do health education, prevention, and screening.
Yeah.
Okay, to do this properly, that's why we're going to come back in a couple months, because 30 minutes is inappropriate time for this. But I love stirring the pot, and I loved having this group today. I'd like to thank my friend Herb Pardis, Bob Grossman, Stan Brezoff, and Steve Saffer. Next week, we have the trustees of many of these institutions giving their opinion of what's going on. See you next week.
Major funding for these programs is made possible by grants from Capital One Bank and Perfect Building Maintenance, Murray Hill Properties, SJP Properties, Cushman & Wakefield, Greenberg Traurig, LLP, New York Community Bank, Bank of America. Additional funding for these programs is made possible by grants from Akron Gold Brothers, LLC, C.B. Richard Ellis, City Investment Fund, ESSEX Capital Partners, XL Realty Advisors, First American Title Insurance Company of New York, Gemini Real Estate Advisors, GVA Williams, Hal Fettner, Durst Fettner Residential, Helmsley Spear, Herrick Feinstein, LLP, Jackson Development Group, James D. Kuhn Real Estate Institute at Syracuse University, James Orphanides, John Katzimatidis, KILROY Metal Products, New York's Window Company, M&T Bank, Madison Realty Capital, Marcus and Millichap, MASSEY NAKAL Realty Services, Meridian Capital Group, Must Development, Newmark Knight Frank, Palin Enterprises, Rosenthal and Rosenthal, Sheldrake Organization, Signature Bank, Sterling and Sterling, Stephen Napolitano, Stonehenge Partners, Studley, the Moynihan Group.